Okay, chapter 20, neurological disorders. So we have cerebral vascular disease. So this is common occurring neurological disorder and described as an interruption of blood supply to the brain. It is the third most common cause of death. Approximately 75% of strokes occur in those individuals older than 65 years. So for our older population, and obviously the focus of this class, 75% of the strokes that occur are in people that are over 65. So we're definitely going to be screening and testing and watching those risk factors for the patients. And it can either be ischemic or hemorrhagic in nature. So ischemic means that there's some type of blockage, and then hemorrhagic means there's some type of bleed. Blockages can come from different things. Somebody throws a clot, somebody throws like a clot of plaque or whatever. That's why having high cholesterol is such a big risk factor for that, but we'll continue with that in a minute. So 4 main types, just kind of talking about that. Arterial disease, so narrowing or blocking of an artery, that's from the buildup of the plaques. Cardioembolism includes those caused by an arrhythmia. So people who have AFib, and I don't know how well you guys understand AFib, so we can go over it if you need to. You have the left atrium that is quivering. It's not actually doing an effective pump. Well, a lot of times people don't know they have AFib. They can be asymptomatic to it. So they have this quivering going on, and therefore you have blood that's pooling, and therefore the blood can clot. If you have these little clots being created in the left atrium from AFib, eventually those can be pushed out and sent through the body. So if somebody has AFib, sends out a clot from the atrium, and then it can end up in the brain. So that would be your cardioembolism, and it includes those that are caused by things like AFib. Hematological disorders, so coagulation disorders, hyperviscosity syndrome. So this is basically saying people who have a bad clotting disorder of some kind, so they don't clot, or people who have super thick blood. So either one of those things, or I'm sorry, the clotting disorders, they don't have thinner blood. I misspoke there. They do not have as thin a blood as they should, or they have this hyperviscosity, which is having this thicker blood. Again, both environments in which we can create clots. And then systematic hypoperfusion may result from dehydration, hypotension, cardiac arrest, and syncope. Ischemic events continued, so there's a differentiation between an ischemic stroke and a TIA. So a TIA is a transient ischemic attack. Symptoms resolve within minutes. And all neurological deficits resolve within 24 hours. So this is something that you'll hear called a mini stroke. Ischemic stroke can be preceded by TIAs. So TIAs can be an indicator that there may be a bigger stroke to come, and there ends up with a permanent neurological deficit. If any of you guys have ever seen or taken care of somebody who's had a stroke in which it was unable to resolve, or they definitely didn't recover fully, you can see those deficits, and we can talk more about those in length together. So a lot of the causes from these ischemic events it's primarily by uncontrolled hypertension. So think about that. If I've got narrowing arteries because of the plaques that are built up around the vessels, and that means I'm going to have hypertension because it takes more pressure to get through those narrowing arteries than it would if those arteries were clear. Well, that's causing trauma pretty much every single time it's blasted through there. I mean, think about that. You have a hose and it just runs out. But if you kink the hose and let it go, you have this big psh because it was being held back. It needed more pressure to get that stuff that had built up out. So it's going to break off things, the little plaques that are on the vessels. That higher hypertension can break things off easier off of the sides of the vessels. And less often, malformations of blood vessels such as aneurysms. So signs and symptoms. The first signs of stroke are The first signs of stroke and transient ischemic attacks, or TIAs, are neurological deficits. If the individual is deeply unresponsive, he or she does not usually survive. So if you find somebody basically down, but they're still breathing, but it's from a stroke, the likelihood of them living is not good. Seizures are common with a hemorrhagic stroke. Nausea and vomiting are common with increased cerebral edema. So if you see somebody puking or somebody having a seizure, these are actually much more deeper, bigger signs of a stroke than the ones that we typically will measure on somebody that we think is having a stroke in front of us. Effects of stroke on motor skills, senses, vision, coordination, cognition, and language depend on the areas that are damaged. Complications. Chances of reoccurrence are increased. So if you have one stroke or you have a TIA, you have an increased chance of having them again. Long-term effects include paralysis, hemiparesis, dysarthria, dysphagia, aphasia, and depression. If you don't know the term or the meaning of any of those words, I encourage you to look them up. If paralysis occurs, individuals may also experience spasticity of the muscles, contractures, DVTs, pressure ulcers, aspiration, pneumonia, and UTIs. So think about that. If I have some kind of paralysis in the left side, let's say, because of my stroke, then I'm going to be at risk for all these things we just talked about, or many of them anyway, because I no longer have the ability to move that right side, or with aspiration or pneumonia. The left side of me with my lungs are not wanting to, I have to use much more forceful coughing and things to try to compensate for that side that I can no longer control. So we can see a lot of complications with that. All cerebral vascular events are emergencies. Management is prevention. So we want to reduce risk factors, administer anticoagulant therapy, administer aspirin therapy, and the whole team is involved for the success for the client. So with anticoagulant therapy, when we have our patients in the hospital, think about how we give Lovenox to everybody. And yes, that's to prevent DVT, typically, especially in our post-surgical patients and people like that. But if I get a DVT, I'm at higher risk for stroke, because if that moves and it's thrown, it's either going to get stuck in my heart or in my brain. Causing either an MI or a CVI. So we want to make sure that, we're administering that stuff and teaching the patient the importance of that. Implications for the GERI nurse. So again, prevention and prep intervention are the keys to management of a stroke. So we want to control blood pressure. If our patients are smokers, we want to talk about the importance of quitting. And, a lot of times we think of when we're going to talk about the importance of quitting to a patient about smoking, we think, well, yeah, we need to tell them not to smoke. But there's nothing wrong with encouraging things like, I could give you a patch. Like if I gave you a patch and you can work your way down on those patches, because patches and gum are definitely better for the patient than smoking the cigarettes. So if we actually present it more in a way of, I know you've been smoking 20 plus years, but I have a 21 milligram patch I can get ordered for you. And, this will help you to, it'll take away the craving for the cigarettes. I mean, it's not going to hurt to give it a try. That can actually be a lot more beneficial in getting the patient to comply versus doing the whole smoking is bad for you, so you should quit. We want to teach our patient to limit salt intake and alcohol consumption and teach them how to maintain a healthy diet. Again, these need to be realistic things that you talk to your patient about. I don't know if any of you have ever been on the receiving end of a nurse or a doctor coming in and trying to teach you how to eat healthy or not drink, but patients are not listening when we're saying don't drink and eat healthy. But if we talk about ways to reduce the drinking first, or different things that they can implement for foods, and so they can still include foods that they like. It has to go to a much personal, deeper level than as simply saying quit drinking, quit smoking, quit eating bad. We do that and the patients just are really not listening. So we have to approach them as we would somebody that we truly love and care about, because I wouldn't just go to my husband and say, hey man, you need to start eating healthy, because he's not going to be listening to me. But if I start implementing changes or teaching how we could implement changes or how he could implement changes, then that would be more beneficial than just telling him to stop. An early ambulation is needed or is necessary. That's especially post-surgical patients. Parkinson's disease is a movement disorder. So Parkinson-like symptoms can be the result of medications, and then is slightly more common in men than women. So the signs and symptoms of Parkinson's, they begin slowly, and so it can be difficult to diagnose because it's not so apparent right in the beginning. So things that we may see or the patient may experience would be resting tremors. This is bradykinesia. So if you see your patient just sitting and resting and they've got that fine little tremor, that's a lot of times a sign of Parkinson's, but it's also a sign of a lot of other things. It can be medications. And I mean, I think today we have more young people than we ever have that have this resting tremor. Fewer overall movements of the body. Rigidity with passive and active movements, including muscles of chewing, swallowing, and speaking. Festination gait. This is short steps with minimal arm movement. So you'll hear somebody talk about the Parkinson's like shuffle or the, you know, how they kind of shuffle along. And we can look at a video of that for those of you who haven't seen it. Flexion of the neck, a stooped posture, and a tendency to fall backward. Small handwriting and appearance, and depression. So management is medications is the focus on replacement, mimicking, or slowing dopamine receptors. So we'll give medications. Levodopa is the primary one that we give for Parkinson's. Actually, that's the next thing. First-line medications include carbidopa and levodopa. Medication therapy needs to be monitored. Side effects may include hypotension, dyskinesias, dystonia, hallucinations, sleep disorders, and depression. And some of you who have followed the whole little Hillary Clinton thing in the news, those where her head was kind of bobbing back and forth from being spooked by the interviewer, that was a dyskinesia that you would have seen in her head if that's the case that she has Parkinson's. There's a bunch of docs out there on YouTube who are saying that's a side effect of levodopa. So that would be something like that you see. Again, I'm not saying that she has Parkinson's, but if she did, that would be something that we might see. Implications for the geri nurse. Treatment focuses on relieving the symptoms with medication, increasing functional ability, preventing excess disability, and decreasing risk of injury. The goal of the treatment is to preserve self-care abilities and to prevent complications. Treatment includes family support, medication, physical therapy, and occupational therapy. And again, remember, we're nurses to the family as well, and the caregivers that are taking care of family members, especially geriatric patients, because so many times they are slightly dependent on someone else for their care. So we have to make sure that our caregivers are not getting caregiver burnout, and that they have the tools and resources needed in order to take care of their loved one. Sickness impact profile or SIP is a useful nursing tool to determine problems most troublesome from the client's perspective. Communication. Categories of impaired communication include reception, perception, and articulation. Reception is impaired by anxiety and an altered LOC or related to a specific disorder such as hearing. Perception is distorted by stroke, dementia, and delirium. And articulation is mechanical difficulties, that's forming your words and things like that, speaking. Speech is affected by articulation as a result of dysarthria, respiratory disease, destruction of the larynx, or stroke. Specific difficulties occur with anomia, aphasia, and dysarthria. Again, if you don't know any of those words, please look them up. I'm actually going to kind of go through these a little bit. Actually, I think I'm going to stop and I'm going to start another one for you because I don't have much time left on this screencast. So I'm going to upload this one as number 1, and then you'll have a number 2 to follow.